Angina and aortic stenosis often occurs without coronary artery disease. The thickened ventricle from chronic pressure overload demands more oxygen, yet perfusion is compromised because of the high wall stress and reduced diastolic gradient. So let's do a question. 64-year-old man has some chest pain on exertion. Mid-systolic murmur, diminished pulses, gradient 55 across the aortic valve. 20% LAD stenosis. What explains this? Well, it's going to be your increased myocardial oxygen demand. Why is it not A? So A, you'd think like a coronary plaque angina usually needs 70% stenosis in order for it to be like a coronary plaque. So no, not that. Coronary vasospasm, those are more common in younger patients with episodic rest angina. So probably not. This is on exertion. And also he's 64. Diastolic dysfunction, that causes dyspnea, fatigue, and it's going to be your classic angina. Fixed stroke volume, so that'll contribute, but it doesn't really explain your angina pain. So what is angina here? Angina and aortic stenosis will stem from your increased oxygen demand and your reduced perfusion. So it's not going to be a blockage here. So you have fixed left ventricle outflow. You can't raise cardiac output during exertion. You get left ventricle concentric hypertrophy. You get wall stress, increased O2 demand, angina without your CAD. Mid-systolic murmur, slow carotid upstroke, pressure gradient. So that thick ventricle from the chronic pressure overload demands more oxygen, and perfusion is compromised because of the high wall stress. And so there's going to be a mismatch, not like a plaque buildup that causes the chest aching. It's all because of that aortic stenosis. Angina, you should just think of like blood supply to the heart is diminished, and the reason why here is because of that aortic stenosis, that hypertrophy, wall stress, increased demand. If you found this helpful, then like and subscribe.